Hello, everyone. Thank you for joining us today for our webinar entitled Advancing Care Information and Meaningful Use in 2017. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's presentation on our website, mceda.org. A copy of today's slides are available there now by going to www.mceda.org. Hover on the Resources tab and then select Webinars. Also, the presentation slides are currently available in the Handouts section of your GoToWebinar interface. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since Medicare and Medicaid policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their content. Today we will start out by giving you a brief overview of MCEDA and our various service offerings. Following that, Bruce will take over and provide you with everything you need to know about participating in meaningful use and the Advancing Care Information Performance category of the Quality Payment Program in 2017. Following the presentation, Bruce will take time to answer any questions posed by the attendees. Housed within Alterum Institute, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of ARA, and more specifically the HITECH Act, MCEDA is Michigan's regional extension center tasked by the federal and state governments with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted nearly 6,000 providers across Michigan, impacting 1.6 million patients annually. Ranked as the 5th largest REC out of a national network of 62, we are also funded by the state of Michigan to assist any provider participating in the Michigan Medicaid EHR incentive program. MCEDA's health IT services include the following. Number 1, meaningful use support at any stage and year. Providers participating in the Medicaid EHR incentive program also benefit greatly by qualifying for state-subsidized services that bring our highly rated technical assistance to you for only $200 per provider, a savings of 96% compared to commercial service rates. Number 2, security risk assessment, which is an embedded service within our meaningful use support. But if providers only need assistance with the SRA, for example, to satisfy the requirements of the new Quality Payment Program, we offer it separately as a standalone service. Number 3, attestation and audit preparation. If you are getting ready to attest and just need some peace of mind that you've crossed all the T's and dotted all the I's, or if you're one of the many folks who have been selected for an audit and need assistance responding, we are here to help. Number 4, targeted process optimization, or TPO, takes a stripped-down version of lean principles and applies them to any clinical or operational practice improvement initiative. No matter what you need help with improving in your clinic, we have experts on hand who can assist. Number 5, the Great Lakes Practice Transformation Network offers no-cost technical assistance to eligible providers in support of quality improvement initiatives, PQRS support, and preparing for upcoming advanced payment model changes under the new Quality Payment Program. Number 6, our Chronic Care Management Program enables physicians to take advantage of the recently updated Medicare billing requirements for CCM services. We provide you with a dedicated care manager who works within your practice, helping fulfill CMS criteria to maximize your reimbursement potential. Contact us to learn more. And number 7, funded by the Centers for Medicare and Medicaid Services, the Quality Payment Program Resource Center for the Midwest provides free help to clinicians in small practices and rural or underserved areas as they navigate participation in the CMS Quality Payment Program. Go to www.qppresourcecenter.com to join today. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you, everybody, for joining me today to discuss ACI performance category, Advancing Care Information performance category of the new quality payment program, and how that compares to meaningful use for 2017. This webinar is primarily designed for folks that are participating in both of these programs in this year, both the ACI or MIPS as well as Medicaid meaningful use are still both alive and well, and to participate in both means a little bit different this program year. So we'll start off looking at some glossary of acronyms here. We like to talk in alphabet soup in healthcare, and I find some folks are unaware of what some of the acronyms are. So if you're not sure what I'm talking about, you might be able to find the answer here on this glossary. Okay, well, let's take a look at who is eligible for both of these programs. Anything above the red line here you can see is identical. So many of the providers that are eligible for Medicaid meaningful use as eligible providers are also eligible clinicians. We have a terminology change, but many of those same providers are eligible for ACI or MIPS as well. So the MDs and DOs, the doctors of dental surgery and dental medicine, doctors of optometry, and nurse practitioners. Those are all eligible clinicians in both programs. Then we start to change a little bit. Everything below the red line, there are some differences here. So only a certain subset of physician assistants are eligible for Medicaid meaningful use. It's usually ones that are in a PA-led FQHC. That means that either the physician assistant is actually maybe owns the FQHC or at the very least sees more patients than the MDs or DOs there. That could be PA-led, but really those are the only ones that are eligible for Medicaid meaningful use. Very different for the ACI or in MIPS. All physician assistants are eligible for ACI. And looking at Medicaid meaningful use, we also pick up the certified nurse midwives, and on the ACI side, we get chiropractors, clinical nurse specialists, certified registered nurse anesthetists, and doctors of podiatry. Some additional requirements between these two programs. On the meaningful use side, of course, we have, again, this is Medicaid meaningful use. The Medicare meaningful use program is now done, and that's really what we have here now in terms of ACI is the kind of new version for Medicare meaningful use. But on the Medicaid meaningful use side, they have the additional requirement that you need to have a minimum of 30% patient volume attributable to Michigan Medicaid patient encounters over a rolling 90-day period or continuous 90-day period. And then for pediatricians, not nurse practitioners in a peds clinic or any mid-levels in the peds clinic, so it's just the MDs and DOs that are technically pediatricians. Instead of a 30% patient volume, they can opt into the program at a 20% patient volume that's attributable to the Michigan Medicaid patient population. Unfortunately, that only pays 2/3 of the incentive, so it's certainly better to get over that 30% mark because you get 100% of the incentive, but you can qualify at 20% and you get 2/3 of the incentive payment instead. On ACI, we have something called the low volume threshold as well. So that looks at Medicare Part B allowable charges. You have to have greater than $30,000 in those charges and provide care to more than 100 Medicare patients in a year. I've got the date range there on the slide. September 1st, 2015 to August 31st of 2016 is the date range that they're looking at for 2017 eligibility. So again, to opt in to the MIPS program, both of those have to be true for the provider. So the provider has to have greater than $30,000 in charges and provide care to greater than 100 Medicare patients. If either one of those is not true for the provider, then they are not eligible for MIPS in this program year. Sometime in April, I've also heard, I think some of these letters are starting to come out now, but CMS is mailing letters to the clinicians who meet that low volume threshold for MIPS exemption. So they are not MIPS providers this year. Those folks will be getting a letter. They've started to mail those over the next several weeks. I think they're going to get those out to providers, so be on the lookout for that letter. I believe the letters are in the hands of the MACs right now, so you should be receiving those. CMS is also on the QPP, or the qpp.cms.gov website, kind of the main QPP website. It's not there now, but I've heard they will also be, there will be a component there on that website where if you are not sure, if you didn't get the letter and you're not sure if you were supposed to, you'll be able to access on qpp.cms.gov. It's not there now, but I believe we should see that in the next couple of weeks. So a place where you can go and check if your providers are MIPS providers or not. So reporting periods on the meaningful use side, new and returning participants this calendar year, so anybody in the meaningful use space. For your meaningful use measures, you have any continuous 90 to 365 day reporting period within this calendar year. So minimum of 90, you can over-report, you can go longer than that. The rationale for doing that is if the provider has missed the mark at the 90-day time frame, but maybe at 100 days or 200 days they are hitting those meaningful use measures, you can extend that reporting period to get to that point where they're meeting those measures. Providers electing the optional stage 3, which is, it is optional this year. You could move into the stage 3 requirements. Otherwise, everybody in the meaningful use is working on what's called modified stage 2, very close to the same definition of meaningful use that we had in 2016. But you can opt to move into the stage 3 requirements if you'd like. And again, you have any continuous 90 days within the calendar year. It's 90 days or plus, just like for the under modified stage 2. You can over-report if you'd like. So anything between 90 and 365 days. You do have to be on your 2015 version of your EHR in order to opt into stage 3. So if your vendor has not gotten you upgraded or you have not fully implemented that new version of your EHR, then most likely stage 3 would not be an option for you. And even if you are on your 2015 technology, you do not have to move into stage 3. You've still got that option to do modified stage 2 this year. So I have this in bold, that third bullet point under meaningful use. This is something I need everybody to pay attention to. If you're multitasking, stop for a second. If you're in the meaningful use space, this is going to throw folks for a loop this year. For returning participants, and this is for meaningful use only, so this is participants who have already attested to meaningful use one time. That doesn't count AIU. That first incentive payment is not meaningful use. That's really an extension of registration. So this is only for folks that have already attested or met meaningful use one time. Your CQMs must be reported for a full calendar year. I can't tell you why. I've been working with CMS and others on this for the past couple of months trying to understand, and to be honest, I don't. So everybody else in all the different programs are on the hook for a 90-day reporting period. Your meaningful use measures, you can report anything between 90 to 365 days. But if you are a returning meaningful user for this calendar year, even though you are only reporting a minimum of 90 days for your measures, your quality measures have to be reported for a full calendar year. Again, not really sure why that is the case, but it is. So what that means is anybody who is a returning meaningful user, you're not going to be able to attest until after the first of the year because you have to do a full year of those quality measure reporting. Okay, so reporting period in this year for ACI then. We've got something called Pick Your Pace. CMS has kind of backed off on the requirements for this year to allow folks some time to kind of ease into this new program. So on the MIPS side, we have the test pace, which is kind of doing the absolute minimum that you can. You are reporting the 4 or 5 ACI base measures. And again, whether you're reporting on 4 or 5 just depends on whether you are choosing what are called transition objectives this year, or if you're going to move into what are called regular objectives or the standard objectives. I'll talk about what those are, so you'll know the difference between the 4 or 5 base measures in just a few minutes. You can do that. That's the test base. It's the absolute minimum. You're just giving what's called the base measures, and again, you'll know what those are as we get a little deeper into this deck. You could also do a partial year or a full year. So under partial year, it's submitting 90 days of data, and a full year is submitting 365. You can also, just like on the meaningful use side, you can be anywhere in between that. You could report for 91 days, 100 days, 200 days, anything between 90 and 365. I'm going to answer a question that I saw pop in because this is a good time to bring this up because I know many of you will have this. Somebody just asked, do we have to report for meaningful use and MIPS this year? Isn't meaningful use included in MIPS? So yes and no. So Medicare meaningful use is done. Medicare meaningful use has turned into ACI under MIPS. But the Medicaid meaningful use program is still alive and well. They are separate programs. You will not get credit for one or the other by participating in just one. You will be attesting separately to both programs if you are in the Medicaid meaningful use program. That is not mandatory. Nobody forces you to be in Medicaid meaningful use. You are not penalized for not being a Medicaid meaningful user. You just wouldn't be able to capture the incentives for 2017 if you choose not to participate in Medicaid meaningful use. MIPS, on the other hand, has some penalties, so you do need to participate in that. However, by attesting to Medicaid meaningful use, you are not going to get credit under ACI. These are separate programs, separate attestations. I've got that listed here as well. But looking at those attestation options, under meaningful use, again, this is Medicaid meaningful use only. It is a manual attestation just like we've had up to this point. You're going to CHAMPS, and then within CHAMPS, it's the EHR MIP program, and you're doing that manual attestation. Under ACI, you've got several other choices here. There is a new attestation portal coming, so if you ever used the federal attestation site that we had under meaningful use, there is a quality payment program version of that on its way. I don't have an ETA on when that's going to be available. It'll come up sometime this year. So you can do that manual attestation for your ACI measures. You can also connect to a registry under ACI, so a qualified clinical data registry or a qualified registry. You can also do EHR Direct if you're connected in that way and your vendor is capable of that. You can send your ACI information directly from your EHR right to CMS. So a few different options under ACI, but under meaningful use, it is just the attestation portal under CHAMPS. The attestation window, so first-time meaningful users can actually attest now. So if you've never attested to meaningful use before, that attestation window opened just on the 1st of this month. So you can get in now, and if you met those measures for the first 90 days of this year, you can go in and attest, and you're done with meaningful use for the year. All others have to wait until next year, and it's because of that issue where you are on the hook for a year of your quality measures under meaningful use if you are beyond that first year of meaningful use. So for the rest of us, we got to wait until January 1st of 2018, and we'll have at least until March 1st of 2018. Not sure if the Medicaid program will extend, but right now, that's the date range you can expect for the attestation window for meaningful use. ACI is similar, but we get a little bit longer on the tail end. The ACI attestation window, and again, this is for MIPS, all of the categories. Nobody can attest under MIPS until January 1st of 2018, and we'll have until the end of March to get those attestations in. And again, if you're participating in meaningful use and MIPS, you must attest separately. You're not going to get credit for one program by attesting to the other. These are separate attestations, separate programs. So looking at the program structure for Modified Stage 2, it is the same as we've had for the last couple of years now under Modified Stage 2. You've got those core, those 10 meaningful use measures. You are attesting to 9 CQMs. That formula means you are a meaningful user. The program structure for ACI is vastly different. We've got 2 different scores that are built, really 3 different scores that kind of build you your overall ACI score. We have the base score, which makes up as much as 50 points. You get your performance score, gives you up to an additional 90 points. There are some ways to earn some bonus points under this. And then it builds this composite score. And again, in the end, you're building your MIPS composite score in the end. But ACI this one component will generate its own score. You could do some quick math here and see you've got 155 points available to you. As soon as you cross the 100-point mark, you have maximized your potential under this performance category of MIPS. So you got to get at least 100 points, and that will earn you the full 25 points that are available in the Advancing Care Information category of MIPS. I'm going to break these down for you as well so you'll understand a little bit more of what this means. So looking at the base score again, it is worth 50 points. This is really the only place where we still have an all or nothing component within ACI, or what was really essentially Medicare meaningful use. They've stripped away a lot of the all or nothing components in ACI, but we still have some all or nothing here. So to get any ACI score whatsoever, you have to achieve the base score at a minimum. So for the base score, you have to do one of everything. I've got two lists of measures here on this slide. You have the 2017 ACI transition objectives, and then the 2018 and beyond, we'll call these the regular objectives. So for this year still, because folks, the majority of providers are not on their 2015 technology yet, they don't have the technology needed to do what is essentially the measures that line up with stage 3. So you can do the transition objectives, and I suspect 99.9% of you are probably going to be doing the transition objectives this year. Even if you are on your 2015 technology, you can still do the transition objectives. Nobody is forced into doing the stage 3 or the regular objectives that are on the screen. Everybody, no matter what technology you're on, as long as it's at least 2014 technology, can do those transition objectives. So in terms of the base score, you have to do one of everything to get those 50 points. So looking at the ERX measure, you need a numerator of 1. Doesn't matter what your denominator is. It can be 1,000,000, it can be 5. As long as you have sent one prescription electronically, you have met the requirements for the base score. Health information exchange. This one will give you some panic. This is the one measure that folks have been trying to avoid up to this point. So this is the one where you are sending an electronic summary of care to that next provider of care for those referrals when you're sending patients out of your practice. You have to send one of them electronically. The security risk analysis, you got to do that. That's not going away. That's the same under meaningful use as it is under MIPS. You have to get your SRA done every year. And provide patient access, that's the equivalent of measure 1 of the VDT or the patient portal measure. So this is the one where you are just providing patient portal access to the unique patients in your reporting period. You have to do it for 1 at a minimum. Once you have a numerator of 1 for that measure, you've met that base score. The regular objectives, the stage 3 objectives, I'm not going to focus too heavily on because there are, I think, very few of you that are going to be doing it. But the health information exchange measure starts to split up a little bit, and you're not only sending that summary of care message, but under stage 3 you're also requesting summary of care documents for patients that are coming into your care, and that's really the difference here in the base score. So then we have the performance score. So again, that base score is all or nothing. You're either going to get 0 points or 50 points. If you don't meet the base score, your performance score doesn't matter because you can't earn anything. So earn your base score by doing one of everything. And then the performance score really looks at your numerators and denominators for some of those measures and all the rest that you're used to being measured on. But there's no thresholds to be met anymore. So whatever your score is, whatever your numerator and denominator is, it's going to translate into points. We've got what those max points are here. Most of them are worth as much as 10 points. There are 2 measures under the ACI transition objectives that are worth 20 that you can see on your screen right now. The provide patient access one and the health information exchange. Those are both base score measures. You see both of those reflected here, so you have to have one of each to get that base score. But then however you did actually perform, whatever that numerator and denominator is on those measures and others, converts into points. And again, you are trying to build at least 100 points under ACI to maximize the points available to you under this performance category. So how do you calculate that performance score? I've got a little grid here. So you take your numerator and denominator, convert that into a percentage, and then look on this grid to see how many percentage points that gives you. Again, you can get worth up to 10 points. There are those 2 measures that are worth 20 points instead. When you're calculating those, you're just going to double it here. So if it's one of the 20% measures, find out where they are on here, double it. So I've got a rudimentary example for some scoring here, and I've got a much more detailed example a few slides from now. But we have a MIPS eligible clinician that submitted a numerator and denominator of 85 out of 100 for the patient-specific education measure. That's going to give you a performance rate of 85%. You look on here, find out where 85 falls, and they're going to earn 9 out of the 10 points available for this particular measure. So example ACI scoring, again, we've got that base score where you're earning 50 points. It's an all or nothing. That's really the only place where we still have an all or nothing component. So you got to do one of everything and you get that 50 points. If you don't get your base score, you don't get any points at all under here. So get those 50 points. You got your performance score that builds up to 90 points. Again, you're just converting your numerator and denominator into a percentage, finding out how many points it gives you. Hopefully you're getting close to those 90 points. You got bonus points here. So under the performance objectives, you'll see that immunization registry reporting is one of them. In terms of public health, that's the only one that is a regular objective. That's the only one you really have to pay attention to. So if you are an immunizing provider and you are, you can attest yes to being actively engaged with MICR, you get 10 points there. Anything beyond that, if you are connecting to additional public health registries, as is the requirement under meaningful use, you can earn some bonus points here. So if you're a non-immunizing provider and you're not connected to MICR, you're not going to be able to attest yes to that, so you're going to miss out on some of those points there. Hopefully, under meaningful use, you're connecting to other specialized registries. You can pick up some bonus points here. Unfortunately, it is 5% total. So if you're connected to 5 registries, you get 5%. If you're connected to 1 additional registry, you get 5%. You don't get 5% for each additional registry. And then they've also tried to link another performance category here, the clinical practice improvement category under MIPS. You can earn some bonus points if the activity that you are implementing to get credit there, you are leveraging your EHR, you're leveraging your health information technology to achieve that goal. It would earn you some bonus points here as well. You add all of those points up and you get your composite score here, earning hopefully somewhere between 100 and 155 points, because that would give you the full 25 points available under this category. I've got another rudimentary example here at the bottom, and I've got a much better one coming up. But we have a MIPS eligible clinician who got the base score, so they did what they needed to there, so they got the 50% or 50 points. They earned 40 points in the performance score and no bonus score. They'd earn 90% of the advancing care information performance category score. When it's weighted by 25%, which it is in this first year of MIPS, this would contribute 22.5 points to their overall MIPS final score. So out of a max of 25 points, they came pretty close. They got 22.5. So some main differences between these programs. Meaningful use is still using the CDS or clinical decision support and the CPOE objectives, but ACI is not. Those measures are not reflected in the ACI performance category. They are still on the meaningful use side though. As I already mentioned, there's no thresholds that must be met in ACI with exception to that base score, so you have to get that one of everything for base, but beyond that, your numerators and denominators are the yes, no, just convert to points. So if under meaningful use, you have to get to a 30% threshold. Whatever your threshold or whatever your numerator and denominator is, just gives you points. So as of today, I think this is going to change, as I've heard from CMS last week, but except for the ERX measure, there are no exclusions for ACI measures. You have to meet that base requirements, and then ECs can, your eligible clinicians, that's what we're calling them under MIPS, can elect on reporting for the performance and the bonus measures. So there is now, there wasn't previously, even the last time I gave this presentation. This is sort of new information that CMS has updated some things, but they have brought an exclusion back for the ERX measure. So it's the same one that we're used to under meaningful use. So clinicians that have fewer than 100 medication orders in the year can claim an exclusion. I've got that reflected in a few slides from now as well. I have heard that there is an exclusion coming for the HIE measure too, but as of today or last time I looked, they have not updated that yet, so it's not reflected here in this slide deck yet. So the scoring is different between the programs, as I talked about a little bit already. Meaningful use is still pass-fail. You have to achieve every one of those measures. If you forget to cross one T, forget to dot one I, you're not a meaningful user. So still very much a pass-fail component of meaningful use. And then except for that base score, which is still pass-fail, ACI uses that decile scoring instead. All right, I've got a much better example here for converting meaningful use scores into ACI. I suggest you do this if you haven't already. You can take your 2016 meaningful use reports and convert those into an ACI score, and that will tell you how you're doing or how your providers are doing if they do exactly what they did last year, this year, when they're performing in ACI. Kind of give you a sense for how they're going to score in this first year of MIPS. So looking at this base score for this sample provider, the ERX measure did extraordinarily well, doing 96% of their prescriptions electronically. This is what we typically see with providers. Everyone is scoring really, really high on this one. So obviously they're well over that numerator of 1, so they get that base score here. Same thing with the VDT, providing that patient access, doing extraordinarily well here at 99%, so they get the base score. The HIE, or summary of care measure, they're doing okay, not doing great, but still getting 25% of those electronically sent. Only needed 1 for the base score, so that scores as yes. And then the SRA, they completed it. That's a yes/no measure. Either you did or you didn't, so you get the base score there. So in this sample, the provider has earned their 50% or 50 points of the base. So then we circle back to the performance score and take a look at all of the measures that are a part of that component of the score. We look again at that HIE summary of care, so taking those numerators and denominators we saw on that previous slide, they count here as well. Only needed 1 for the base, but they got 21 out of the 83. That converts to a 25% success rate. Looking back at that grid you saw several slides ago, that would earn you 3 points. It is one of the ones that is doubled, so we get 6 points for that one instead. The other one that doubles is next, the VDT, the patient access measure on the patient portal. They did really well on this at 99%. That converts to 10 points. This is the other one that doubles, so you get 20 points for that one. Then the usage, this is how many of your patients are actually accessing your portal. This particular provider is doing fairly well, getting almost half at 43% of their patients to use it. Gives them 5 points. This one is not doubled, so the score is 5%. Patient education, 97%, doing very well. You get the full 10 points there. MedRec also doing very well at 92%, get the full 10 points. Secure messaging, in this example, they're not doing great. Only 31 out of 432 for 7%. Only earns you a decile score of 1. And then MICR. Again, this is a yes/no measure. Either you did it or you didn't. So you're either going to get 0 or 10 points. This provider is actively engaged with MICR, so they earn those 10 points. So overall, they get a performance score of 62. You can see they did really well on some measures, not so well on some others. We look at the extra credit, or the bonus part, bonus score. This particular provider went above and beyond MICR, so not only are they connected to MICR, they're either connected to the syndromic surveillance registry or any number of other specialized registries that would count. They're answering yes to that, to 1 or more of those extra registries, so they get the 5% bonus here. But they did not select any of the clinical practice improvement activities that would have earned them some bonus points here. So they don't get that 10%. So they get a final bonus score of 5%. Wrapping that all together, we get that base score of 50%, that performance score of 62%, and a little bit of bonus gives you 117 points, or 117%. You're topped out at 100%. So if you look, looking back at the performance score, even though they did not great on the secure message, they were doing really well elsewhere, and they more than earned what they needed to get the full maximum 25 points here. And what we're seeing here is if you are achieving Medicaid meaningful use, that usually, not always, but usually translates into the full 25 points under meaningful use. So you don't have to hit it out of the park. You don't have to be a perfect meaningful user to earn those 25 points. If you're hitting the Medicaid meaningful use thresholds, if you can attest to being a Medicaid meaningful user, chances are you're going to score really well under MIPS as well. Just taking that exact same information, convert it over to ACI, and you're going to come either right at 25 or very close to that 25 points. All right, we're going to get into the actual objectives and measures now, kind of comparing and contrasting them. Again, I am really only looking at the transition objectives under ACI, because I think that's where 99.9% of you are going to be this year. So the measures are almost identical, except for the CDS and the CPOE. As I mentioned earlier, those 2 measures are not a component of ACI, but they are still alive and well under Medicaid meaningful use, so you still got to pay attention to them there. But we've got, other than that, the measures are all the same. And now I'm going to go into each one of those measures and talk about the differences, if there are any, between meaningful use and MIPS or ACI. So under Objective 1, we've got that security risk assessment. This is the meaningful use measure. Same thing we've been doing up to this point. You got to either do a new EHR or a new SRA, or you can update your previous SRA. One thing to note is when and if you have new technology, your old SRA can't just be updated again. You have to redo your entire SRA anytime you're on new technology. You're only able to kind of update your last year's SRA if you're on that same technology again this year. I will also pause here to point out that it's not enough to do your SRA. You need to be working on whatever your previous SRA identified as an issue. We see over and over again, we see folks get their SRA, they get their results, they pack it away, and they don't look at it again until the next year. You are in a serious audit problem if that's your MO. Especially on the Medicaid side, they are looking in very great detail at whatever was identified on that previous SRA. And if you are not showing that you are making corrective actions and plugging those holes and getting those policies in or whatever the previous SRA identified, there's a good chance you're going to fail your audit. So don't be in that boat. Not only do you have to do the SRA, you need to over the course of that year be chipping away at whatever that SRA identified as a problem. ACI, it's exactly the same. It's the same SRA. You don't have to do separate ones. You do one SRA per year, and it's going to give you credit in both of these programs. But again, under ACI, you've got to get that security risk analysis done every year. In terms of scoring, it is part of that base score, so it's a yes, no, you either did it or you didn't. It's not part of the performance score, and there's no bonus for doing it here either. But in all other ways, it is the exact same measure. CDS, again, there's no equivalent to the ACI measure here. This is the same as we saw under modified stage 2 last year. You're implementing 5 CDS interventions that are related to 4 or more CQMs at that relevant point in the patient care. Absent those four CQMs, or the ones that are related, absent the 4 CQMs related to the EP's scope of practice, you have to just choose the high priority health conditions like hypertension or diabetes. It's really 7 CDS rules that you have enabled here, because measure 2, looking at enabling the functionality for drug, and drug allergy, those are CDS rules. They have them split out as just enabling that functionality that your EHR can do. But in essence, this measure is looking at enabling 5 CDS rules. 2 of them have to be the drug, and drug allergy. This is the other one that does not have an equivalent ACI measure, is computerized provider order entry, or CPOE. We've got 3 measures here. One thing to note, transitioning from 2016 meaningful use to 2017 meaningful use, is there are no more alternate exclusions. Those are gone now. Under this objective last year, measures 2 and 3 had alternate exclusions tied to them, so you didn't necessarily have to report, but those are gone now. Everybody's on the hook to report measures 1, 2, and 3 unless you qualify for the regular exclusion. So under measure 1, looking at medication orders, it's greater than 60% are recorded using CPOE. Measure 2, greater than 30% of your labs are recorded using CPOE. And measure 3, 30% of radiology, greater than 30% of radiology orders are recorded using CPOE. Again, there are regular exclusions here, but no more alternate exclusions, no kind of free pass on measures 2 and 3 this year. Electronic prescribing, ERX. So the same as we saw last year under modified stage 2, carries forward into this year as well. So greater than 50% of all permissible prescriptions written by the EP are queried for a drug formulary. That is an important part. You need to have a drug formulary enabled in your EHR. And you're transmitting them electronically using CERT. There is an exclusion here. So the EPs who write fewer than 100 med orders during that reporting period or don't have access to the pharmacy can claim an exclusion. Similarly, under ACI, it's really the same measure, but again, we don't have that threshold that needs to be met. It's really the only difference here. So whatever that numerator and denominator is, in this measure, and this one sort of only, you only have to get 1. Anything beyond 1 under ERX in this program doesn't really buy you anything additional. So you got to get to that threshold for meaningful use. But once you get 1 in this reporting period for ACI, you've met the objectives under MIPS. But other than that, it's really the same measure. And there is an exclusion here. It's relatively the same exclusion that we have under meaningful use. So any MIPS provider who writes fewer than 100 permissible prescriptions could claim the exclusion here. But again, if you have 1, as long as you have 1 in your numerator, you don't need to claim the exclusion. You can just attest to meeting that base score requirement. So it is part of that base score, but this one doesn't translate into the performance score. So as I mentioned, under this program, once you have a numerator of 1, that's all you can get. That's all the credit you can get under electronic prescribing. Health information exchange under meaningful use, same as we saw last year. You've got greater than 10% of those transitions of care. These are the patients you are sending out of your care into another provider of care. You're using your EHR to generate that summary of care document and electronically transmitting it to the next provider of care. Got to do that for greater than 10% of those transitions, but there is an exclusion. So anyone who transfers a patient or transitions a patient or refers a patient fewer than 100 times during the reporting period can claim the exclusion. That's the same exclusion we've seen each year up to this point. Under ACI, I have heard that they are making a change and bringing that same exclusion into this program, but as of right now, I don't believe they have made that official update, but I have heard that it's coming. We'll have to wait and see when and if they post that, but as of right now, I don't believe it's there. But other than that, it's really the same measure. It's taking your transitions of care, generating that summary of care document, electronically transmitting it to the next provider of care. You have to do it for at least 1 to get that base score. This is the one that is part of that base score. And then whatever you get beyond that, hopefully it's more than 1. But this is one of the performance measures, so whatever your numerator and denominator is, you convert it to a percentage. And this is the other one that doubles. You get up to 20% here. So you get a lot of points if you're doing really well under this measure. Patient-specific education. Same as we've seen under modified stage 2 in the past, greater than 10% of those patients are getting some patient-specific education resources flagged and given to them. There is an exclusion on this one if you don't have any office visits. This is one of the ACI measures also, and it's essentially the same thing. It is the same measure, it's just scored different. That's the only difference here. So it is not part of that base score, but whatever that numerator and denominator is, it's going to convert into a percentage and earn you some points here. So exact same measure, just scored different. MedRec is really the same. Again, just like we've seen in the past, we've been working with this one for several years now. Threshold is still at greater than 50%. So anyone that is coming into your care, you are doing that MedRec by any means possible. And if you were not the recipient of any transitions of care, you claim an exclusion here. And again, it's really the exact same measure under ACI, it's just scored different. So exact same thing being measured in much the same way, but there's no threshold that needs to be met. Whatever that numerator and denominator is going to earn you up to 10% here under the performance score. Patient electronic access, VDT. So we've got a little bit of a change here under meaningful use than what we've seen in the past, but not to measure 1. Measure 1 is exactly the same as we've seen for several years now. So greater than 50% of your unique patients seen during the reporting period are being provided access to your patient portal. Same thing we've done in previous years. Measure 2, however, is a little bit different. Last year, we only had to get 1 patient to log into your patient portal. We are back to a percentage. You've got to have greater than 5% of those unique patients actually logging into your patient portal. So be aware of that. It's not just the 1 anymore. We're back to 5% of your patients need to actually use your patient portal to achieve meaningful use this year. Under ACI, the provide patient access, this is the equivalent to measure 1. This one is split into 2 slides. So this is the equivalent of measure 1 under VDT. So it's, again, the exact same measure. It's just scored differently. So this one is part of the base score, so you have to have at least 1 to get your base score. And then whatever that numerator and denominator is converts to a performance score. And this is the other one that's doubled, so you can get up to 20% or 20 points here. The other side of it then, this is the equivalent of measure 2 under meaningful use under the VDT measure. This is the one, how many patients are actually logging into your patient portal and using your patient portal. Under meaningful use, you've got to get greater than 5%, but whatever that numerator and denominator is converts to points under ACI. So again, it's the same measure, just scored differently. You can earn up to 10% here, depending on how many of your patients are actually logging into your patient portal. Secure electronic messaging, no changes. No, I'm sorry, there is a big change here. So last year we had to send one secure electronic message to achieve meaningful use. We are back to a percentage, much like measure 2 of VDT. We are at greater than 5%. So again, that is you sending secure messages to your patients is what earns you numerators here. You're going to get greater than 5% to achieve meaningful use in 2017. Again, this is a change from last year. We only had to do one secure message last year, but we are back to a percentage of your unique patients now at greater than 5%. Secure electronic messaging under ACI is the exact same measure, just scored differently, much like we're seeing with all the rest of them. It's really the only difference here. Same measure. It's not part of that base score. There's no threshold that has to be met to achieve ACI. Whatever that numerator and denominator is, just converts to points. You can get up to 10 points or up to 10% here. Public health reporting, we've got another change here. This is the other one that had alternate exclusions attached to it for 2016. Those are all gone. No more alternate exclusions. No more free passes here. So this year in 2017, all of the meaningful use participants must attest yes to 2 out of 3 of these measures. We've got 3 options here, as we've seen before. Measure 1 is the immunization registry reporting, or the MICR. Option 2 is not really an option for the majority of providers out there anymore. Syndromic surveillance reporting is only available to hospitals and urgent care settings. So if you're not a provider in either of those settings, you are not connected to syndromic surveillance anymore, and you cannot attest yes this year to being actively engaged with syndromic surveillance. So option 2 is not an option for the vast majority of providers. We get option 3 though, it's to pick up the slack with specialized registry reporting. There are a lot of registries that qualify as a specialized registry. The state has some fantastic ones like the Cancer Registry or MITRE, Birth Defects Registry. If any of those work for you, I highly suggest you connect with those. There are a lot of other ones out there now, and it seems like more and more every day that would qualify as a specialized registry. So there's a lot of options out there. Hopefully you can find one that not only meets your scope of practice and helps you as a clinician, but is also not really expensive either. Unfortunately, some of these registries, these specialized registries, can be very expensive to connect to. So hopefully you're able to find one that's doable from a financial side. So you have to do 2 out of 3 of these measures. So it's most likely an immunization registry measure and then a specialized registry, or it could be 2 of the specialized registries to achieve this as well. But you've got to be actively engaged with at least 2 to achieve meaningful use here. On the public health reporting side of ACI, it's really just the immunization registry. That's the only one that we really have under ACI under these transition objectives. You're earning either 0 or 10% here. It's not part of that base, so it's either yes or no. If you are an immunizing provider and you're actively engaged with MICR, you're going to get the full 10 points. If you are not, then you are at 0. There are, again, some other options here to get bonus, though. Under ACI and public health, MICR is the only one that kind of is part of the performance score. Everything else, if you're connecting to specialized registries to achieve meaningful use, they're going to earn you some bonus points. So it's not part of the base score. We were looking at syndromic surveillance, not part of performance score. But if you are connected to the syndromic surveillance system, you can get up to 5% here. And same thing with specialized registry reporting. Again, if you are achieving meaningful use, that means you have likely connected to more than one registry, and you can get some bonus points here. But again, you don't get 5% for each additional registry that you connect to. It's up to 5% total. All right, got some concluding thoughts before we get to some of the questions. I see we've got about 10 minutes left and quite a few questions that have come in. So meaningful use in ACI or MIPS are separate programs. Participating in one is not going to give you credit in the other. You're going to be attesting separately to each one of these. Although meaningful use is not a requirement, you don't have to participate in Medicaid meaningful use. I urge you to. There's a lot of money to be made there yet in terms of your incentives. If you haven't claimed all 6 of those incentive payments, I would urge you to continue in that program. But you don't have to be a Medicaid meaningful user. If you are a Medicare provider, you do have to pay attention to MIPS or ACI, however. But again, those are separate programs. Participating in one doesn't give you credit for the other anymore. And although they are separate, they are, as you just saw, very, very similar. It really comes down to different scoring. The objectives are almost identical with the exception of CDS and CPOE, but other than that, it's really just about different scoring. Meeting meaningful use on the Medicaid side likely means a decent, if not max ACI score. And really, more often than not, we are seeing a meaningful user, a Medicaid meaningful user, almost all of the time getting the full 25 points under ACI. And so this is a really important consideration, though, is that goal should no longer be just meeting the meaningful use threshold. With ACI, every numerator and denominator converts into points, and it could mean an increase in your Medicare reimbursements. So if you've got a meaningful user who isn't doing so well and is like struggling to meet meaningful use, again, it's no longer about just meeting those thresholds, because you could still do, a struggling meaningful user could actually still do really well under ACI. For instance, if you're, every numerator counts. So looking at that VDT measure under ACI, it's about providing patient access, and that's one of them that's worth 20 points. So it's no longer about hitting that 50% mark. You want to get as close to 100% as you can, because getting to 100% on that one measure would allow you to slack off in other measures and still get a great ACI score. So it's no longer about meeting those meaningful use thresholds. It's about doing the best you can on every measure to ensure that you are capturing the full 25 points available. Not only that, I do want to point out that your MIPS score is going to be publicly available. So you want to do the best you can, because providers or patients are going to start shopping for docs that have better scores. So that's another thing to consider. Your MIPS score is going to be publicly available on the Physician Compare website with CMS. So you want to make sure that whatever is reflected on that site is as good as you can possibly be. Because again, that site will allow patients to shop around and use that metric as a determination for where they're going to seek care. So don't just meet the threshold. Do the best you possibly can. I've got some resources for you here. The QPP.cms.gov website is today the best place for you to go to get more information on the Quality Payment Program. It's a fantastic site. CMS has done a great job of giving you resources there, and they are continually updating that and providing additional resources. So I highly suggest the QPP.cms.gov website. Very soon, you saw Liz talked about the QPP Resource Center, the new Quality Payment Program Resource Center that we are about to launch. The framework for that site is up live right now and is taking signups for that service. But I would urge you to interface with us in that way as well. Go to QPP Resource Center, sign up now, and we will be live with a wealth of great resources for the Quality Payment Program very, very soon there. We've got some other great resources for you here as well, like some ACI performance category fact sheets. The meaningful use specification sheets are there as well. So if you need a little more detailed content, go to any one of these resources. And with that, we'll get to the multitude of questions that have been pouring in as I've been talking on and on. We'll get to as many of these as possible by 1 o'clock. Unfortunately, I've got a hard stop today at 1, so I do need to wrap up. If I do not get to your questions by 1 o'clock, know that I have your question, and you will hear from me via email. How are non-prescribing providers dealt with under the ERX in the base? So that is why they have added an exclusion back into that measure. So this question is relative to the ACI performance category, and we're looking at the ERX measure. If you are a non-prescribing provider, then you are going to qualify for the exclusion there. And if you qualify for that exclusion, it is as though you met the requirements for that base. So a non-prescribing provider would just claim the exclusion, and you would still earn that base score as a result. Non-prescribing providers, such as doctors of chiropractic, will not have one in the ease prescribing. How is that handled? Okay, so that's the follow-up. So I just answered that one. So if you're a non-prescribing provider, you're going to claim the exclusion, and that would still allow you to earn that base score. HIE has an allowable exception for meaningful use if the provider transfers fewer than 100 patients in the reporting period. So, given this allowable exception, meaningful use can be met without sending anything via HIE. However, it sounds like ACI requires something to be sent via HIE. So am I correct in understanding, even though an EP is compliant with meaningful use, they can never be compliant with ACI if they're taking the allowable meaningful use exception under HIE? So as it stands today, that would be the case, but I have heard, just like just last week, they added the exception back in under ACI for the ERX measure. I heard from CMS last week that they are doing the same for the HIE measure. So from what I understand, although last time I looked, they have not added it back in, but I have heard that they're working on that update. That was an oversight on their part, but there supposedly is going to be an exclusion for the HIE measure. So again, just like ERX, if you qualify for that exclusion, you would be able to report a null value there, a 0 out of whatever your denominator is, and you'd still be able to earn that base score. Can providers attest to both Medicaid meaningful use and MIPS? Absolutely, and you absolutely should if you can. Again, Medicaid meaningful use is not a requirement. You are not penalized in any way by not being a Medicaid meaningful user. You would just miss out on the incentives for this year. But if you've achieved Medicaid meaningful use in the past and you've not captured all 6 of those incentive payments, I highly encourage you to continue in that program. And then you would also attest to MIPS. It is a separate program. You are a MIPS provider if you meet that low volume threshold that I talked about on the front end. If you're a Medicare provider meeting that threshold, you have to participate in MIPS. Otherwise, you're going to get hit with a penalty this year. But again, you don't have to participate in meaningful use. And participating in meaningful use does not give you credit for MIPS. I can't stress that enough. These are separate programs that you'd be attesting to separately. In regards to the HIE ACI measure, do we need to have a certain number of cases to earn the 20 points fully? Nope. It's whatever that percentage is. So even if you had 5 transitions of care and you sent all 5 of those electronically, that's going to give you 100%. It's going to earn you that full 20% or 20 points under that measure. Our EHR has recently outsourced quality reporting to a vendor. Does this qualify as new technology that requires a new SRA? No. When you're doing your SRA, it is just on your EHR. So no, that would not mean you have to do a new SRA. It's just when you get upgraded, when you have a new EHR, you have to do a new one. Do you have performance deciles for the ACI measures? Yes, and we covered that in here. So you look in the slide deck, it gives you what all of those decile percentages are for the ACI measures. I don't remember what slide that is specifically, but look back in the slide deck and those deciles are there for you. Question on Objective 5, ACI. I am having a hard time finding a definite explanation of transition. We are cardiology. If we refer someone to pulmonology because we heard something on exam, is that considered transition for this reason? I assume that if we refer to a subspecialist, heart transplant, etc., that would be considered a transition. Absolutely. Yeah, anytime you are sending a patient to another provider of care, certainly any kind of specialist or additional specialist or subspecialist, those would all count. There is some leeway there on what you would count as a transition of care, but at a minimum, you have to count any referrals. So anytime you are referring a patient to another provider of care, that would count as a transition of care. one thing to think about is in the paper world or in the non-electronic world, ask yourself, when I'm sending this patient on to that next provider, would I have sent some records along? Would I have photocopied something out of the paper record and faxed that over? If the answer is yes, that probably would count as one of those transitions of care. So you might think about it that way. Would you normally send records along to that next provider of care? If the answer is yes, you probably should be counting them. All right, we are at 1 o'clock. I'm going to answer one last question, and then all the rest of you, I apologize that we are out of time, but I will follow up with you as soon as I can with answers. Let's get to this one last question. If we do not immunize in our practice, are we just out those points? Unfortunately, yes. So you are, I guess, harmed or hurt. You're kind of docked in that way because under ACI, the MICR measure, immunization measure, is one of the performance measures. So you get that 10%. If you're a non-immunizing provider, you do actually lose out on the ability to capture that. And then you can only earn some of those points back through bonus points. So you could earn 5 of those points back through bonus, but the MICR measure is worth 10. So yes, you are actually kind of docked some points here. However, with 155 points available total, and you only need 100, I'm hoping that doesn't mean that's really gonna ultimately hurt people, because you can easily get to over 100 points by picking up and doing better in all the other measures. So if you're non-immunizing provider, yes, you have the potential of losing 5 points or 5% there. But you can, I think it should still be, you're still capable of picking up all those lost points through the other measures, and ultimately would still earn the full 25 points. Okay, unfortunately, that is all I have time for today. Again, I will pick up all the rest of these questions. You will hear from me via email. Thank you so much for attending today. I look forward to seeing you again on some future webinars, and stay tuned. You can go to the www.mcda.org website, and you can access our webinars page there and keep up to date on any of our upcoming webinars. Thank you so much, everybody, and we'll see you soon.